As you can see, this is a longitudinal lie and cephalic presentation, longitudinal lie breech presentation. What's meant by presentation? Presentation means part of the fetus that occupy the lower uterine segment, or part of the fetus which is encountered by vaginal examination. And what are the types of presentation? Presentation type include cephalic presentation, which is about 96%, breech presentation, which is about 3.5%, and shoulder presentation. Cephalic presentation, as you can see, it contains three different types. If the head is fully flexed, this is known as vertex presentation, and if the head is fully extended, this means that face presentation, and if the head between flexion and extension, it will be known as brow presentation. So, cephalic presentation include vertex presentation, brow presentation, and face presentation. Cephalic presentation, as you can see that the vertex is the area of the vault bounded anterior by the anterior fontanelle and the coronal suture, and posterior by the posterior fontanelle and the rhomboidal suture, and laterally by two lines passing through the parietal eminence. The face means the area from the junction of the chin and neck to the root of the nose and the supraorbital ridge. By brow we mean the area from the root of the nose and the supraorbital ridge to the anterior fontanelle and the coronal suture. As you can see, this is the vertex, which mean the area bounded between anterior fontanelle and the rhomboidal suture, and the posterior fontanelle here, posterior and rhomboidal suture. Sorry, the anterior fontanelle and the coronal suture, the posterior fontanelle and the rhomboidal suture, and two imaginary lines passing through the parietal eminence. Regarding the anatomy of the skull could be divided into face, base, and vault, and the vault is divided into brow, vertex, and occiput. Why cephalic presentation represents about 96%? Because of two theories, the adaptation theory and the gravitation theory. By adaptation theory we mean the small part of the fetus has to occupy the small part of the uterus, and so the head occupies the lower uterine segment, and by gravitation theory the heavier part of the fetus occupies the lower part of the uterus, and so the head is the lower part occupying the lower part of the uterus because it is heavier. As you can see, this is a longitudinal presentation, longitudinal lie, transverse lie. This longitudinal lie, the head is a low dominant, so it's known as cephalic presentation, and this is a cephalic presentation. Here it is longitudinal lie, but the most dependent part is the breech, and so the presenting part is the breech, the part of the fetus which presents itself to you, or the part of the fetus which occupies the lower uterine segment is the breech, and so this is known as breech presentation. And here this what's known as shoulder or transverse lie, shoulder presentation. Again, this is a longitudinal lie breech presentation, and this is a shoulder presentation, and this is a shoulder presentation. Again, longitudinal lie cephalic, longitudinal lie cephalic, longitudinal lie breech, longitudinal lie shoulder. What's meant by position? Position means the relation of the back of the fetus, whether to the right or to the left side of the mother, and whether it's directed anterior or directed posterior. So we have 8 different positions. By far the most common is the first position, in which the back is left anterior, followed by the second position, in which the back is right anterior, and third position, the back is right posterior, and the fourth position, in which the back is left posterior. Then we have 4 rear positions, which include direct anterior, direct posterior, left transverse, and right transverse. As you can see, if this is the occiput and it is directed posterior, this is known as occipito-posterior position. But if the occiput is directed anterior, it will be known as occipito-anterior position. And if the occiput is directed anterior a little bit to the left side, it will be known as left occipito-anterior, then left occipito-transverse, then left occipito-posterior. Here, this is the right occipito-anterior, the right occipito-transverse, and the right occipito-posterior. What's meant by denominator? The denominator means it is a poly landmark on the presenting part which denotes the position, and the denominators that we have to know include the chin in case of face presentation, the sacrum in case of breech presentation, the scapula in case of shoulder presentation, and the occiput in case of vertex presentation. The occipito-anterior position is much more commoner than the occipito-posterior position because of, number one, concavity of the fetus has to fit in the convexity of the mother. The concavity of at the front of the fetus, inflection attitude, fits into convexity of the vertebral column at the back of the mother due to lumbar lordosis. Shorter diameter, the engaging diameter in occipito-anterior is the suboccipitopragmatic, which is 9.5 cm, while the diameter is the occipitofrontal, which is 11.5, and so occipito-anterior is much more common than the occipito-posterior position. The left anterior is more common than the right anterior, and the right occipito-posterior is more common than the left occipito. The head in the left occipito-anterior and right occipito-posterior enter the right oblique diameter, which is more favorable as the pelvic column reduces the length of the left oblique, and anatomically the right oblique is usually slightly longer than the left oblique diameter. What's meant by attitude or fetal habitus? Attitude means the relation of the fetal part to each other. In vertex presentation, so to decrease the surface area of the fetus is in a state of complete flexion. On the opposite side, in face, there is complete extension of the head, and the military attitude means the head neither extended nor flexible. There is an important definition you have to know, which means asyncretism and syncretism. What is the definition of syncretism? Syncretism means the two parietal bone has to be at the same level in the pelvis. Asyncretism, there is lateral inclination of the fetal head in which two parietal bones are not at the same level, and so the sagittal suture of the head deflect anterior toward the symphysis pubis or posterior toward the sacrum. What is the value of asyncretism? It brings the shorter subparietal supraparietal diameter, which is 9 cm, to enter the pelvis instead of the biparietal diameter, which is 9.5 cm. The incidence, there is a slight degree, may occur during normal labor. Let's say it is a step during the normal labor, but it has to be in the form of a slight degree. Asyncretism is more evident with contracted pelvis, especially with flat pelvis. By normal syncretism, the sagittal suture lies midway between the promontory and the symphysis pubis, but the sagittal suture might deviate anterior or posterior. And so we have two types of asyncretism: the anteparietal bone presentation, in which the lower, most dependent part of the head will be the anterior parietal bone, and so the sagittal suture will be directed a little bit toward the promontory. On the opposite side, if you feel the posterior parietal bone, the first part of the fetus which is encountered during vaginal exam, this means that posterior parietal bone presentation or posterior asyncretism, and on that time the sagittal suture is directed toward the symphysis pubis. We have to know whether the anterior syncretism is better or the posterior. The anterior syncretism is better and favorable prognosis simply because the sacral promontory is the only resistance that the head has to pass in order to enter the pelvis, and there is less stretch on the anterior wall of the lower uterine segment, and so the possibility of rupture uterus is less. And thirdly, the fetal head is more or less in the direction of the pelvic axis, and so the prognosis of anterior syncretism is much more better than the prognosis of posterior asyncretism. Engagement means the passage of the widest part of the presenting part through the plane of the pelvic end. Let's say the biparietal diameter in head presentation. What is the time of engagement? The time of engagement in a prime gravida is about 3 to 4 weeks before the onset of labor, let's say around 37 weeks, and in the multigravida, usually it occurs at the onset of labor at the beginning of the second stage. What is the significance? If engagement occurs, this denote or exclude this proportion. How to diagnose? You can diagnose it by history, like disappearance of the upper pressure symptom and the appearance of the lower pressure symptom. And on examination, you can do what's known as fetal head station. You can know the station of the fetal head by doing abdominal exam or local exam. Abdominal exam, when you do first pelvic grip, you will fail to grasp the presenting part because it will recede. Second pelvic grip, you will feel divergence of your hands. Or you can use the rule of fifths. If less than 2/5 of the head palpated, this means that the head is engaged. Is more than 4/5 of the head is palpated, this means the head is still hard. And in between, fixed or not engaged. You can diagnose by vaginal exam using what's known as dilatation. The level of the ischial spine is taken as 0 station. Above this level by centimeters are described -1, -2, -3, and so on. And below that level, the centimeters are described +1, +2, or +3. This picture represents the dilatation. This is as 0 station, and this is -1, -2, -3, and this is +1, +2, and +3. What are the causes of non-engagement of the fetal head in the last 3 to 4 weeks in a primary gravida? Everything in obstetric has to be divided into 3 P's: the power, the passage, and the passenger, and you have to add other. Regarding the power, which may be primary or secondary power, here is there is atony of the abdominal wall, or if there is tonic lower uterine segment, this will delay the process of engagement in a primary gravida. Regarding the passages, the polypelvis, if there is contracted pelvis or pelvic bone tumor, or soft tissue like tough vagina, rigid cervix, or if there is a pelvic mass like a placenta previa. The passenger, which means the fetus, fluid, placenta. So if the fetus is hydrocephalic or oversized head, or malpositioned or malpresented, or if there is multiple pregnancy, or the cord is too short or too long, and so it might produce 2 knots around the neck of the fetus, all of this will delay the process of engagement in a primary gravida. And other like the fluid, if it increase polyhydramnios, or it decrease oligohydramnios, or if there is a full bladder or rectum, or miscalculation.